De'Ara Matthews gave birth to a healthy baby boy in 2009. She named him Charlie. All went well for the first month until something terrible happened. Early one morning, De'Ara brought Charlie into her bed to nurse him, and after he ate, they both fell asleep.
I woke up again, he was still laying there, but there was something, like he had like blood in his nose at this time. And so I picked him up. He was really, really warm, and I wasn't sure why. I thought maybe because the heat, he was like the heat was dry. So I was thinking maybe he had a nosebleed because of the heat, and I kind of shook him a little bit to try and see. And I realized he didn't move, and I realized he wasn't breathing. So I kind of put his face like next to my face to see what was going on. I yelled for my husband to get up.
They rushed Charlie to the hospital, and after a short while, a doctor came out to talk with them.
I remember him saying that there was nothing they could do, and that my son had made it. And it didn't hit me right there, because I'm thinking maybe they made a mistake, or they're in the wrong room. They're talking to the wrong family. They could possibly talk to me, because this doesn't happen to me.
De'Ara Matthews is just one of tens of thousands of women who experience an infant death from many different causes in the United States each year. Despite having some of the world's best doctors and hospitals, our country has one of the worst infant mortality rates in the industrialized world. How can we explain this? And more importantly, what can we do about it?
What is more important than saving the life of a newborn? How can you, if you care about anything at all, you got to care about that. If you have any empathy for individuals, any human compassion at all, this has got to be an important issue.
And what's even more alarming is that in certain parts of the United States, and for some minority populations, especially African Americans, Hispanics, and Native Americans, the rates are far higher even than in many developing nations.
In what people might call ghettos, and communities like Harlem, communities in Chicago, communities in the border states, these communities are poor. They don't have power over their lives, the people, the women that inhabit these communities. And so the health system is not responsive to the needs, of these particular women and their family members.
By working to reduce the infant mortality rate overall, and particularly the racial disparities, we can accomplish several other important goals as well.
If you do what you have to do in reducing the infant mortality rate of a community, then you're not only making it possible for more babies to survive past their first birthday and to live long and productive lives, but you've also changed your entire healthcare delivery system for the better, because infant mortality stands as a barometer of the public health of a community.
Today, across the country, people are coming together to address this problem through a national initiative called the Collaborative Improvement and Innovation Network to Reduce Infant Mortality. CoIIN for short. Its partners are collectively taking important steps to address this issue in communities nationwide.
In essence, what we're doing is we're bringing together state leaders, public health leaders, those that are interested in any capacity, particularly across multiple sectors, to come together using collective impact as our framework to address infant mortality on a systems level.
In our infant mortality CoIIN, the national CoIIN, there are 6 main strategies. They include promoting safe sleep, promoting smoking cessation, promoting perinatal regionalization or risk-appropriate delivery of perinatal care, the social determinants of health, focusing on those, as well as looking at pre- and early-term delivery, and then the last one would be looking at preconception and interconception health.
One place that has made tremendous strides in this area is Harlem, New York. Back in the early 1990s, infant mortality was a staggering 27 deaths per 1,000, one of the highest rates in the nation.
We didn't have the type of resources to cover all women in Harlem in the 5 zip codes that make up what we call Central Harlem. But we did have enough resources to concentrate our perinatal, our clinical, and public health resources in a small 4-block zone. To the right, you have the St. Nicholas houses, which is our housing development. It was the base of our zone, MCH zone, where we spent 11 years going door to door and meeting the needs of the families that live in that particular development.
We know that the health of a woman, the health of a family, before she becomes pregnant is very important to the outcomes of her baby. And so anytime that we're able to help mitigate all of those challenges that we know influence infant mortality rates, or set up communities so that they're not able to care for themselves in the way that they would like to care for themselves, if we have that opportunity to help bring those folks to the table who can help impact, whether it's housing and having quality housing, or having better paying jobs, or having time off from work so that you can care for your baby and care for your family, whether you can get food and afford food, all of these factors influence how well a woman is able to take care of herself while she's pregnant.
The work in Harlem has been very successful. From a high of 27 deaths per thousand in 1990, they've dropped the rate to 7.5 deaths per thousand in 2012. And now, through CoIIN, they're sharing this experience with others.
By pooling all of this knowledge together, we can create, 1,000 points of light across America, and taking the best practices from different sites around the nation and executing them, collectively around the country. I think that that's the promise of CoIIN right now.
Another success story can be found in Cincinnati, Ohio, which has struggled with appallingly high infant mortality rates for years.
I was stunned at how bad it was in Cincinnati, and in a larger sense in Hamilton County, that here in a community as wealthy as we are in terms of raw wealth, socioeconomic standard for the majority of people, and in a community as wealthy as we are from the standpoint of hospital resources. We have one of the best children's hospital medical centers in the nation, right here. And right outside of their window is one of the worst infant mortality rates in the nation, if not on the planet.
Whether we like it or not, healthcare institutions are going to be held accountable for the health of populations. And although we can boast about how wonderful our programs are, I can tell you how outstanding our NICUs are. If the overall health of our community is still poor, if our infant mortality rate is still way too high, if our preterm birth rate is too high, then it doesn't matter if we have an outstanding neonatal intensive care unit. We have to really engage in a larger space.
But now things have begun to change for the better in Cincinnati, too.
One of the key things that we are doing differently from most other initiatives is we have the community involved at the very beginning.
When you start to then come together as a group and say, break it down and say, these are some of the things that we think that you can do, people see that that's doable. You can't make someone go, you can't get rid of poverty. But as a community, you can come together and talk about how can we best reduce unsafe sleep. And it really is the power of the community, because everyone is going to approach things in a different way, and everybody's cultural competence and voice gives a contribution.
We've been able to, I believe, make some significant impact already around at least certain categories of infant deaths, specifically sleep-related deaths. That's very exciting, and at least is, if not a proof of principle, some indication that our strategy has a sound basis.
And in Baltimore, where infant mortality has also been very high, they've been experimenting with using women at risk to work with other women at risk. Deara Matthews is at the forefront of this movement. She's turned her grief over losing her little boy Charlie into helping other women who have recently lost a baby. through a support group sponsored by the Baltimore City Health Department called Charlie's Circle. The hope is that not only will she help these women get through their grief, but it will also help others reduce their risk of losing an infant.
I'm able to meet these women. I'll hear stories like, I went to prenatal care at this office and they were very rude and I've been trying to switch, but no one will accept me. I don't have transportation to get there, and they're wanting the absolute best, but they're meeting these roadblocks.
There's very poor housing in Baltimore City. So while we wanted to pay attention to these modifiable determinants and have always kept a trajectory looking at our indicators around smoking and pregnancy, around infant safe sleep, we've always kept our eye attuned to what the root determinants are and have small working groups that also start to address those factors.
I think it's very important to know the root of the problem, to start from the very bottom, to try and figure out what the barriers are. Why aren't these women able to access services? And how can we make it easier for them to access services? And what needs can we meet? So if we want to get some prenatal appointments, how can we get them CAB vouchers to get there? How can we make sure it's the transition? If they're not comfortable, you have to be comfortable with your OBGYN. If they're not comfortable, how can we make the transition easier for her to get to a new one? How can we help her with childcare if that may be an issue? If she has, or how can we help her as far as her job? Some of these women are working 2 jobs to support their families. They can't take days off to go to a prenatal care appointment. How can we open weekend clinics so that way these women can go to the clinic on Saturday? When they have time off, because they work these positions or these jobs that don't have paid time off. So if they miss a day off going to a prenatal appointment, they miss money for rent or money for gas and electric or money to put food in their kids' mouths, and they can't afford that.
We've seen a decline from 13.5 deaths per 1,000 live births to 10.3 deaths per 1,000 live births overall. More significantly, the Black infant mortality rate has declined, the racial disparity has declined by 62%.
Above all else, it's critical to remember that this problem is not just about statistics. It's about our future, our babies. And when we lose even one, that loss can have a profound and lasting effect on those who love that baby.
I am very optimistic that CoIIN will have an effect because I think we are tapping into a substantial energy and enthusiasm that the states have to really combat what has been a persistent and really bedeviling problem. So everyone wants to do better. Some of the issue has been we're not exactly sure how, but this CoIIN opportunity allows states to really see what's worked in other places, and that can facilitate and accelerate improvement because you can try things that you know have worked in other places and don't have to start from scratch.